Welcome, first of all, to this MS Academy webinar. My name is Ruth Dobson. I'm a clinical academic neurologist based in East London. And it's really great to be joined today by Dr. Andrea Stennett from Bart's MS and from Rob Sloan from Shift MS. And what we're going to be talking about today is we're going to be talking about how we can understand and start to mitigate some health-related disparities in MS care. So in terms of who you'll be hearing from today, you'll be hearing from me and only briefly, which is probably a good thing. And then Andrea is going to talk to us about some of the evidence around health-related disparities in MS care. And Rob is going to be talking from a patient perspective around some of the impacts of this. So we've got an absolutely brilliant couple of speakers lined up, and then hopefully we'll have time for some discussion at the end. So this activity has been sponsored by Sandoz, but they've had no control of the organisational educational content of the activity, but we'd like to thank them for sponsoring this activity around a very important topic. So what are the objectives for this session? So we've got CPD accreditation for 1 hour of CPD for this session, and we're aiming to help meet the following objectives. So looking at evidence around ethnicity and social determinants of health affecting outcomes in MS, and to improve understandings around how health disparities might influence approaches to assessment, treatment and management of a person with MS right across the MS journey. So right from first contact with healthcare services to their management of MS and also its related complications. And I think more importantly, how do we actually work together and how do we work to ensure better access to healthcare regardless of gender, race, sexual orientation or other characteristics that may be implicated in poor access to healthcare? And how can we consider the impact of health disparities on MS care when we're service planning, both nationally but also locally, because we know that many of these factors are have impact at a number of different levels. This is obviously, for anyone that's heard me sort of say anything about anything really, a topic that I think is really, really important. It's a major source of inequity, both across the UK and internationally. And it's great that we've got different voices coming together to actually talk about this and really move this forward. So just in terms of a bit of background, I think when we've all been taught about MS, either at medical school, at college, at university, this is the kind of picture, and I think when a lot of my patients come into clinic, this is the kind of picture they have of Jacqueline du Pré, of a white female in their prime of life struck down by MS. But actually MS is far, far more than this. As we know, people living with MS are a vastly diverse range of people in all senses of the word. MS is not a discriminatory disease. It affects everybody, it affects many people differently. But actually part of what comes to your MS is your personal circumstances, your personal background. And this is really, really important. And we talk a lot about personalised care and tailoring our care to the individual. But actually, there are systemic level factors that may influence how different people experience MS. And this is against the background that MS studies in general almost exclusively enrol from specialised healthcare services. The populations who are in clinical trials don't always represent the populations that we treat. In order to get access to clinical trials, for a start, you have to be treated in a tertiary centre, which is enrolling for that trial, which automatically excludes a substantial number of people from the get-go. And then once you start taking into account inclusion criteria, access to healthcare, biases on the part of healthcare professionals who may be recruiting to trials in terms of who might be suitable for the trial, you start to narrow down that window massively. Because it's, people do not have equitable access to healthcare. People don't have equitable opportunity to be diagnosed at the same disease stage, and this really follows through the disease course. And we increasingly understand the long-term implications of early treatment initiation, yet we also increasingly understand that this may not be being felt equally by all of the people with MS across the UK or internationally, because healthcare access can be such a divide. There's a digital divide, there's an education divide, and Andrea really is going to speak to this in a lot more detail than I can. And, there is increasing emphasis on the importance of social determinants of health, not only in multiple sclerosis, but across the wider world, across the wider arena of healthcare. And what are social determinants of health? Well, they're pretty much everything. They're the conditions in which we are born, live, work, and age. So this is regardless of your health or disease status, you are all surrounded by social determinants of health. They're part of what makes you who you are. And I think as we reflect, we will come to hopefully better understand through this webinar how these may impact on how people living with a chronic disease experience their disease, how they may influence the outcomes, and also influence the ways in which they experience their world. So that's it in terms of introduction. So without further ado, hand over to Andrea, who's our first speaker, who's going to be talking to some of the evidence around this in MS. So Andrea, over to you.
Okay, hi everyone. So first of all, I'd like to say thank you to the Academy for the invitation to be part of this panel discussion. And as Ruth said, very timely, very relevant topic at the moment, entitled Understanding and Mitigating Health-Related Disparities in MS Care. And as I move through the presentation, what I want to do is really to highlight some of the existing health-related disparities and to initiate discussions around how we can mitigate some of these for people with MS across the UK. But before I start, I think it's important to set the context, and I think we really need to define what we mean by health-related disparity. And I really like this definition because it's very comprehensive. So it defines health-related disparity as a type of health difference that is closely linked with economic, social, or environmental disadvantage. It adversely affects groups of people who have systematically experienced greater social or economic obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, or mental health, cognitive, sensory, or physical disability, sexual orientation, or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. So quite a mouthful, but I've highlighted some of the key terms which we need to really consider as we're moving through this presentation. It's largely health differences, it affects groups of people, and these people are historically linked to discrimination or exclusion. The other thing to say quite early on is that what we see in clinical care and clinical practice is often a mirror image of what we see in a wider society. So we know that health disparities can lead to health inequalities, and these are largely avoidable, unnecessary, and unjust. And as a whole, health inequalities can lead on to health inequity. So behind the backdrop now of MS, we know that there are approximately 2.8 million people living worldwide with MS. 85% tend to have the relapsing remitting form, 12% the progressive form of the condition. And within the UK, we know there are approximately 130,000 people living with MS. And this is just a breakdown between Scotland, England, Scotland, Northern Ireland, and Wales. So females tend to be more affected than males in a ratio of 2:1. Some studies suggest that it could be as high as 2.9:1. And we know the age range for diagnosis is what we consider the prime of life, so between 20 and 40 years, when people are just about to start a family, start a new job, or enter start education. But the key thing I want to highlight with this slide is that the majority of people living within the UK are within the state pension working age. And we also know that people can live for decades with MS. So then what are some of the known disparities that we see in people with MS? So if you look at MS and ethnicities, especially if you look at the prevalence data, what we see is that prevalence varies by ethnicity, whereby MS predominantly affect white individuals, but more and more we're seeing an uptick in incidence of MS among Black individuals as well, but much higher than previously thought. We also see younger age of symptom onset and diagnosis, and this we see within the Black and the Asian people with MS. When you look at disability and symptom burden, We know that this increases with age across males and females and across all ethnic groups. But when you compare the literature and you look at ethnicity in particular, what we see is that with Black people with MS, they tend to have a more severe form of MS, a more aggressive type of MS. They tend to have more relapses. They tend to have more attacks within the optic nerve and spinal cord involvement. We also see walking coordination and balance impairments. In fact, for Black people with MS, we tend to see a shorter time to EDSS-6. They have a higher risk of requiring a walking aid much earlier. They tend to have a greater risk of developing wheelchair dependency. And they tend to present to nursing homes much earlier in age than, for example, white people with MS. And when you look across cognitive impairment, so we know in MS, cognition can affect up to 40 to 70% of people with MS. We often see even changes earlier on. For someone who is newly diagnosed with MS, you can see actually subtle changes in their condition. But again, when you look at the ethnicity data, what we find is that Black people with MS tend to score lower on cognitive assessments comparatively to white individuals. Interestingly, when you dig down into that data, you also see that even the healthy controls score low on cognitive assessments compared to white people with MS. And for that reason, we think there's something else that might be at play beyond MS. And I'll touch a little bit about that as we move through the presentation. But we also see differences in terms of responses to certain DMTs and tolerability. And we know that mortality rates also differ by ethnicity, whereby Black people with MS tend to die at an earlier age than white people with MS. And some literature even suggests that Black males are at a greater risk of dying before the age of 45. So what does this all mean? When you look at the data collectively, what we see is that Black people with MS, they tend to have worse MS outcomes than white people with MS. And this has implications for in terms of access to treatments, in terms of implications for resource allocation and policy decisions, but it's something that we need to address, and perhaps we can start the discussions around that. So I can hear your brain sticking away saying, okay, Andrea, so what's causing all these differences? To be honest, the jury is a little bit out on this. So some studies suggest that genetics may be at play, but again, it doesn't tell the whole story. So my colleague, Ben Jacobs, he's leading on the ADAMS study at the moment. I think that will give us some insight. Other studies suggest that there might be environmental factors at play. There might be bias as well. So Ruth alluded a little bit to that. We can discuss that again later on. There might be also delays in terms of, from the healthcare side of things, delays in diagnosis, but we can also see that sometimes there could be delays as well from the person living with MS in terms of seeking medical assistance. But more and more, the literature is pointing towards what we call social determinants of health, that these can actually has a major contribution to health outcomes as well in people with MS. So I'm going to tag a little bit there. So what do we mean by social determinants of health? So the World Health Organization defines this as the non-medical factors that influence health outcomes, the conditions under which people are born, grow, live, work, and age. And this diagram here is just to highlight to you some of the conditions or some of the determinants that are at play in people's lives. So for example, individual factors like gender, sexuality, race, and ethnicity, other factors like education and housing. The key thing to say here is that social determinants of health, or these determinants, they tend to give us an idea about how healthy people are. And then inequalities in any of these areas can actually affect health outcomes. The other thing to highlight with this slide is that largely these interplay with each other and they overlap. So sometimes it's difficult to tease out what's at play. So moving on, so when we look at social determinants of health within the wider context, you always hear about this north-south divide within the UK. And the key things to highlight here is that social determinants of health, they're not distributed evenly across the population. And we know they influence health inequalities, and they account for approximately 30 to 55% of health outcomes. And just to put that in some context for you, just to give you an example. So we know life expectancy is a measure that we can actually use to look at how healthy a population is, for example. And what we see within the UK is that life expectancy differ across geographical regions. So people who live within the northeast, northwest of England, they tend to have the lowest life expectancy. People in most deprived areas, certain ethnic minority and health inclusion health groups, they spend much longer in ill health and die sooner. We see people in deprived areas are more likely to have long-term conditions. In fact, they tend to have multiple long-term conditions. And when you look at the severity, it's quite severe in people from lower socioeconomic backgrounds compared to people from higher socioeconomic backgrounds. We also see that people who live in the most deprived areas are up to 4 times more likely to die from an avoidable cause. And here, what we're talking about, avoidable cause, are like causes that can be averted. So averted either through timely interventions to healthcare, or through public health measures or preventative measures. So when we look specifically at MS, then what we see as well is that social determinants of health can affect MS outcomes. And I'm just going to tease some of this out for you. So education, we know that education influences occupation, income, and wealth. And higher education tends to be protective against disability progression in people with MS. And for people with less years of formal education tend to have a higher risk of reaching EDSS 6. And low levels of education is associated with worse MS outcomes and linked to smoking, unemployment, reduced health literacy, and socioeconomic status. Again, when you look at socioeconomic status and MS, there's evidence to suggest that there is an association between low socioeconomic status at disease onset and greater disability. We see faster retinal neurodegeneration. And the interesting thing that's coming out in the literature as well is that socioeconomic status may or may not be associated with DMT initiation and escalation decisions. So some studies say that it has an impact whereby people from lower socioeconomic backgrounds aren't able to access the type of high efficacy DMTs. But some studies say this does not have an impact. But when you look at the studies and where they're done, I think it might be dependent on geographical location, and it also has something to do with health systems. So whether universal health system versus health systems that you have to pay to access care. But something to be aware of. Socioeconomic status as well has been associated with increased hospitalization and greater excess death rates. I like this study. So this study really highlights what's going on a little bit within the UK context. So the authors here, they looked at HES data between 2020 and 2021. And what they found, and they looked across 4 regions. So one in the northwest of England, 2 in the southeast, and 1 in the southwest. And what they found was that social determinants of health are associated with greater comorbidities and hospitalizations. I just want to highlight this table here for you as well, because what it shows is the 12 most common comorbidities that's listed on hospital records. So the top 3 are hypertension, mobility problems, and urinary tract problems as well. And the ones highlighted in green are usually linked to deprivations, so type 2 diabetes, smoking, and obesity. So with my physio hat on, just looking through some of these comorbidities, I can say that rehabilitation or lifestyle interventions can actually keep some of these comorbidities at play. But again, access and utilization of health services might be at play here, but that's another discussion for another time. So I'm going to move on now to how can we mitigate for some of these health-related disparities that we see in MS care. And I think we really need a comprehensive, multi-layered, and multi-systems approach. And just to share a few thoughts, a few ideas with you as well, you can let me know what you think. So I think we need to work collaboratively. So there's a lot of work going on in a wider context. And I think we need to have an appreciation or know what's going on there as well. So just to highlight this document to you, it's a new policy document developed by NHS England and NHS Improvement, really to reduce healthcare inequalities, and they provide the tools necessary to make it work. Just to explain it quickly, so there are three key components. You have the core 20, and the aim for the core 20 is really to look at what's going on in the most deprived 20% of the population, to see or to examine the impact deprivation has on things like access to care. And then the second component, the plus component, is just an additional component that focuses on local inequalities. And here the ICS integrated care systems play a much larger role here. And I think for people, for our group in terms of has a focus with MS, we need to link closely with ICS groups locally to ensure that resources are allocated and distributed fairly across the regions. In fact, because they have this local initiative, I think this is where we can really advocate to raise awareness within the ICS or ICB groups about the impact MS has, and also some of the healthcare disparities that we see within our population. And then the 5, what it means is just the 5 clinical areas of priorities as listed in the NHS long-term plan. The other things to highlight on this slide is that the NHS England also have on their website the NHS inequalities, the health inequalities improvement dashboard. So that can give you an idea about what's going on in your local area around inequalities. And I think also we need to learn lessons from other areas. So for example, in maternity care at the moment, there's a lot of funding going in to address some of these healthcare disparities within maternity care. So we can learn to see from them, to see what they're doing and the outcomes that they're having. Research. So we need a data-driven approach. So most of the studies that I presented earlier on really is coming out of America. So they're leading the way with this. And I think there's emerging evidence from the UK, but we need to build a stronger evidence base. We need research not only focusing on a top-down approach. So we know top-down approaches can work because, we need the experts, we need policies and so on. But I think if we can marry the top-down approach with a bottom-up approach, so to include the lived experiences of people with MS, to really identify and understand some of the challenges that they face, whether it's from different ethnic groups or underserved communities, I think this will build a stronger evidence base within what's going on within the UK to really see what's going on in our catchment area as well. We need to be creative. So Ruth alluded to this a little bit, because we need to involve more people from different ethnic minority groups, various socioeconomic groups, older people, and people who are more disabled. So one of the studies I'm involved in at the moment, Chariot MS, we're looking the study is such that it's designed to have more disabled people with MS. But we need funding, we need grants to really address some of these health disparities and improve outcomes. But another thing I'd like to say about research here is don't forget about your audits and service improvement projects, because this gives you local knowledge about what's going on in your catchment areas. And please, 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 if you're working on any projects, do share them with the academy so we can actually start building the evidence base around this. Education. So one of the key things I think we need to do is have a wide range of initiatives to raise awareness about MS, its symptoms, and its impact across all communities. I think we need to do a little bit about like what they did in stroke, target the general population, keep MS in terms of its impact and some of these health-related disparities on the lips of the wider community as well. So from time to time you hear MS comes up in the news and then it dies down again. We need a sustained message and narrative around MS, its impact, and we need to engage community groups and religious groups and charities. Also, just to highlight as well, as Ruth said, MS can affect anyone. And one of the things that we need to do is make sure that the information that we're providing and education resources are in different languages as well to reflect the population that we actually see. Cultural awareness and education, I think it can go a long way as well for our healthcare professionals. And I put a little asterisk here around workforce. It's not the focus of this presentation, but I also believe that if you have a diverse workforce, it will help to meet the needs of a diverse population. And when we think about access to healthcare, I'm just going to highlight a few things here. We need to ensure better access to healthcare, irrespective of gender, ethnicity, and sexual orientation. And one of the things as well around social determinants of health, I think we don't screen for it. So we can't identify it. We can't tell if our patients are having challenges in any of these areas. And this is just to highlight some screening questions that you can ask, simple questions to really initiate the conversation around social determinants of health. Just be mindful that some of this might be sensitive. We know people might not want to disclose some of the challenges they are having, but I think we need to initiate a conversation and to signpost people to the necessary support that we have access to and that they can possibly benefit from. I just want to say as well, one of the simple things that you could do during your consultation is just ask a question. So, winter is coming up. So you could say something like, winter is coming up. Are you concerned about heating your home? It's just one question that you can use to initiate that discussion. Also, we need to advocate for policies to ensure DMTs are accessible to those who need it, irrespective of geographical location and socioeconomic status. So I've presented some information to suggest that this might not be the case. And the other thing to highlight here is that we probably, as a community, we probably aren't utilizing rehabilitation services, social prescribing, vocational rehab as much as we could do. And I know there are issues with services at the moment as well. But as you can see, this can be a possible solution. Navigating the NHS can be a challenge. It can be a barrier to some people, especially if English isn't their first language, or maybe they've moved to the UK and the health system is new to them. So navigating and getting access to care might be a challenge. So we need to be aware of all of these. And coming into land, we need to assess, monitor, and review. We need a strategic and coordinated plan. These are complex issues, really. So we need to find ways to monitor, review the disparities across our teams, locally and nationally. And the other thing I want to say about this is we need the data to drive the implementation plan. There are existing tools out there, so we might not need to reinvent the wheel, but what we do need is to modify it for our people with MS. And remember that social determinants of health, they are not static, they can change. So we need to review policies and make the necessary adjustments. And perhaps this is something to think about. Maybe we need our MS task force to really address health disparities in our patients. Because if you have a group that will drive this, I think it can make a difference. So in conclusion, there's a lot of work to do, but we need all hands on deck, really. And these are big issues. There are challenges. So we really need that collaborative approach, working with people with MS and all the key stakeholders as well. And the key thing to take away from this is that health inequalities, they're avoidable, unnecessary, and unjust. So we can really make a dent here. We need to start with what we have access to. So we have access to patient records. Are they updated? Start there, for example. Link in with your local ICS groups. What about your service improvements and audits? Maybe we can start there to start building our evidence and use that then to move on to further research, because we need a greater understanding about the differences in MS outcomes with respect to ethnicity and underserved communities. There's a lot of work to be be done within the UK. And we need early access to DMTs, rehabilitation, and supportive care. I think these are keys to delay disability progression as well in our patients. So I'm going to leave it there. I want to thank you very much for listening. And let's continue the conversation around this topic. Thank you.
Thank you, Andrea. That was absolutely brilliant. And what a fantastic overview of a massive topic. I think we gave you a tough task to cover it in what was originally sort of 15 minutes, and then we gradually extended it. But it was absolutely brilliant and really well kept to time. So there is the Q&A button open. We're planning to have questions sort of addressed to both Andrea and Rob at the end. So please do put questions in as they occur to you. And then we can sort of discuss some of the issues. I've certainly got a few things to ask. But I'd like to, without further ado, hand over to Rob Sloan. So Rob works with Shift MS and really is going to give us a sort of, I was going to say opposite, it's not really opposite perspective, but different perspective on some of these challenges. So very much with a patient focus. So over to you, Rob.
Brilliant. Thanks, Ruth, and thanks, Andrea, for that talk. That was brilliant. And thanks to the Academy for having me here today to talk as well. Great. So as Ruth mentioned previously, I'm Rob Sloan. I work as a service designer at Shift.ms. Shift.ms is a social network for people with multiple sclerosis. It's a charity based out of the UK. I'm calling in from Montreal today, so I'm a little bit further afield. But we've been sort of set up for about 15 years. I'm going to be talking today a little bit about, if I can get my slides working. Oops. So I'm going to be talking today about evidence of the disparities in MS care as we see them, as we sort of engage with our community members. And that's both sort of on the social network itself, but in the design and delivery of our services as well. And I'm going to talk a bit about how we mitigate against care disparities in the services that we design as Shift.ms. And I'll also be sort of pulling to light some examples of how others are doing it as well. So as I mentioned, Shift.ms has been going for a while, about 15 years. It was started by George Pepper, who was diagnosed in his early 20s, at a time, Ruth alluded to this, when people are sort of making big decisions about their lives, major lifestyle decisions, working out what they want to do career-wise, relationship-wise. It comes at a time when you've sort of established who you are in your teens and sort of early 20s. So you have you're starting to form an idea of who you are as a person, and then suddenly you're diagnosed with something that's incredibly potentially sort of life-changing. So George, when he was diagnosed, he couldn't find anyone who he related to. He couldn't find anyone online as well. So he was quite surprised about that. And in reacting to that sort of unmet need, he set up Shift.ms, which was effectively a very simple forum back then. We roll forward about 15 years. The service has grown to just under 60,000 members. It's a worldwide membership, although about 40% of our users are based in the UK. And as I mentioned, we're a sort of a UK-based charity as well. Our target audience is within 2 years of diagnosis. This is when we found through evaluation that we have the highest impacts when uncertainty is at its greatest. So I've tried to build this presentation a little bit around what we call our logic model, which is similar to a sort of theory of change. If you're unfamiliar with with these sort of types of model, effectively what they try and do is illustrate the problem that you're trying to solve as a service and the change you're trying to make, the solution that you're trying to sort of build towards. And what you've got here is, on the left-hand column, the evidence of the problem that you're tackling, the needs that you're sort of surfacing in your user base, and then all the way through to the right is the outcome that you're looking to get to and the change you're looking to make. In the middle, it's what you do as a service to help sort of join the dots and solve that problem. So the bits I'm going to be focusing on are really sort of the evidence and the needs section on the left-hand side. These are MS community-wide needs, but what I thought would be good was to talk about the MS community and the needs of the MS community on a population level, and then to use that as a lens to identify cohorts within the community for whom disparities in care or who are at most risk of encountering disparities in care, I suppose. So to start with the first sort of evidence need area, the reason why Shift.ms was set up in the first place was to tackle the isolation that George was experiencing around diagnosis. And we know that this is not uncommon amongst the newly diagnosed. So more than half of people have felt isolated as a result of being affected by MS. So services have a need or have a duty to help people protect, maintain, and build their human connections. So we think about sort of, I suppose, extreme user cases and people who are likely to meet disparities in MS care. If you have any sort of determinant, if you have any challenge that's unique to you, that level of isolation potentially goes up a level, because you're less likely to find people who you relate to. You're more likely to feel isolated, alone, and there are potentially long-term impacts there in the sense of you feeling confident to engage in your health management, in care services, etc. So in terms of one area to focus on, I could have chosen sort of many different determinants here, but if we look at sort of ethnicity, if you were diagnosed with MS and you're from a community, there's a quote here, someone who's from an Egyptian sort of ethnic background. If you're coming from a specific community with specific challenges, and you feel like you can't find people who are like you, who I suppose whose story resonates with you, whose background resonates with you, you're less likely to engage sort of socially with services like peer-to-peer services like Shift.ms. And there's it's something that comes out again and again in our research, is this feeling like a minority within a minority. You're already entering a minority when you're diagnosed with a long-term condition like MS. But if you have sort of additional challenges, then that's another layer that you need to sort of tackle. It's not enough just in terms of sort of peer support, which is a great way of dovetailing traditional models of care and offering sort of additional levels of support that dovetail, doctor's appointments and engage, points of engagement with your clinical team. If you're not finding the people who you relate to sort of to engage with during that time, then you're less likely to be on top of your health between appointments, to be sort of self-managing and having high enough levels of self-efficacy. So in terms of the, I suppose, ways that we've mitigated this challenge, so when Shift.ms was first founded, this is not dissimilar to what you'd see when you first arrived on the landing page. It's slightly more overwhelming, deliberately so, but when you joined the service, you were met with a number of profiles, faces of people who were active on the service. But when we conducted co-design groups and research groups, we found that this was actually putting off a lot of people. It's not enough just to be living with a condition to get on with someone else. That's not enough of a common ground. So we're finding that people were judging the whole service based on who they were seeing on this page, and then leaving immediately. We found that there's research out there that shows initial touch points with health services and systems are incredibly important, because if it's an uncomfortable or bad interaction, then you're put back in a worse place, confidence-wise or self-efficacy-wise, than when you started, and are less likely to engage with your health in the long term. So these first touch points with users and with patients are incredibly important. So what we did was we sort of flipped the model on its head a little bit, and instead of seeing this wall of people, we designed a sort of a search engine for the MS community. So you could find people sort of through a bit of technology on the site, in specific age groups. You could find people who've been diagnosed at specific sort of points in time, and also just down to location as well. Being able to understand someone's experience based on where they are sort of locally is incredibly important. And this sort of brings me on to another area that I wanted to flag, which is sort of rurality. And this is really sort of a socioeconomic determinant. But we conducted a study a couple of years ago, and in that study we found that around half of the population find it challenging to get to appointments, no matter where they're located. But a quarter of respondents cited they live too far away to get to appointments easily. and a huge amount of those are in Canada, but I think it's still true of the UK. But what's important here is that there's your location has an incredible impact on the level of care that you have access to, the treatments that you have access to, depending on what's available at your local centre. But also in terms of sort of isolation, it's not enough to, you need to be connected, I think, with in terms of sort of peer support with people who really get your sort of local challenges that you're encountering. A service that we've developed to sort of mitigate this, I suppose, is we have a buddy network service. So this is a service where we partner people up with someone who's a little bit more experienced, so through that diagnosis process. So it's a 6-month partnership. And this was a learning for us. We were sort of partnering people up based on simply the amount of time they'd been diagnosed and perhaps sort of on a country basis. But actually, the area within the country where someone is living is incredibly important. We try and sort of connect people based on locality as much as possible to build, I suppose, more meaningful connections and increase the chances of longer term engagement in services like peer support and in health as well, in self-management. So this is a Nesta diagrams of outlining the role of peer support. So peer support is a bottom-up sort of grassroots movement that is leading towards social inclusion. What services like Shift.ms can do is, from a top-down perspective, they can offer networking help, so we can sort of accelerate that curve, that upward trajectory. And then the second thing we can do is also offer resources and learning opportunities, and I'll come on to that in a second. So the second key need area that we address as a service is around emotional and psychological well-being. So the evidence need here is that people with MS are 2 to 5 times more likely to develop mental health problems such as depression, anxiety, and the need for MSs is that they need to cope emotionally and psychologically with the diagnosis. So if we're talking about cohorts within the community who are particularly susceptible or to whom I suppose disparities in healthcare could occur, I want to flag the audience of male MSs. So this is generation-wide data, but so men are 3 times more likely to die by suicide than women, and also there's only 36% of referrals to the NHS are talking therapies for men. So we have a quote here from a Shift.ms member who was essentially sort of unaware of the emotional challenge that would be encountered at diagnosis. So something that we do as a service, as I mentioned, is to provide sort of resources or learning opportunities for people sort of using the service to supplement the peer support that we offer. So one of the services that we offer, sorry, this is jumping around a bit, I think I've got a bit of a lag. One of the services that we offer is was actually launched in reaction to the global to COVID-19, to the pandemic. And this is at a time when health services were struggling to incorporate people living with MS or patients in the design and delivery of their products. So we work with Jo Johnson, who's a psychologist who works as part of the MS Academy's program as well. And we took an acceptance and commitment therapy program that she had that was delivered in person for the police, and we digitized it and made it relevant for the MS community. So we did that by sort of building what we call a learning collaborative. So we're a peer support platform. We don't provide information on a top-down basis. What we try and do is create sort of bottom-up, sort of peer-driven means of informing or delivering resources. So we sort of recruited a number of MSs, Mike being one of them in the centre, and we created sort of a workshop environment where, with Jo, they were working through a number of exercises that were from this acceptance and commitment therapy course. So the course itself, it was a number of podcasts and sort of video casts, if you like, so almost like a Headspace style approach. and it was delivered over the first year of the pandemic. And one of the things that I wanted to talk about, or I thought this was important to talk about, was that the model itself which is really sort of a smaller take on peer support, it's sort of stolen from an educational model, which is a collaborative or cooperative learning model, where you bring people together, you bring pupils together who work collectively on a shared challenge, and they draw on the skills, the varied skills and experience of the group to navigate that challenge. And one of the great things about this particular model is that there's nowhere to hide in sort of smaller groups, and it provides a brilliant an encouraging environment for people to share and to be vocal and to participate. And this was incredibly important. We've seen the statistics about men not sharing around their sort of health needs, and this was a way that we sort of designed that into the product. So these sessions were filmed and then disseminated and sort of made available to the rest of the community who followed the course with them, and it was supplemented by live sessions as well. Okay, so the final sort of need area that I wanted to reference was this is around self-efficacy. So an individual's confidence to be able to, or their self-belief essentially in the fact that they can manage their health. So the evidence shows that around 62% of MSs experience low or declining belief to manage their health following diagnosis. And again, this is sort of an MS population-wide statistic. And there's a need there that people need to believe that they can influence their health outcomes, in order to then take the next step and actually play a part in their health, in their management, and to just engage with their care teams fundamentally. So the audience that I'm going to be referencing in this instance is women with MS. So we took Andrea sort of mentioned earlier that women with MS form the sort of biggest cohort of patients, but despite this, there are still sort of unmet needs in this community, which is quite staggering. So we went out to our membership with a poll and asked what's the sort of biggest unmet need, or what's the biggest challenge that women are experiencing with multiple sclerosis. And there are a number of needs highlighted there, but the biggest unmet need, or the biggest sort of challenge that people were encountering, was what's called symptom gaslighting. We have a quote here talking about how someone's symptoms for years were just put down to effectively hysteria, which is quite a stark quote. So there's a real sort of deep set problem in the way services are tackling sort of female MSs and female patients that sort of urgently needs to be addressed. And in terms of what's happening and so what we're doing as a service, well, we're trying to raise awareness through things like polls. So polls on our forums are a really great way of driving engagement and driving sort of really rich conversation. So we can highlight some of the challenges that communities are facing through sort of essentially UX mechanisms. Then we can bring to light some of these challenges, and we can effectively form sort of smaller collaborative learning groups in the conversations that follow, where people talk about how to navigate the challenges that they're experiencing together. In terms of what's happening in sort of the wider world, I think we've touched on the needs for representation in clinical trials and research, but I think we can take it a step further and talk about representation at an even higher level in the world of research and the world of science. And this is a prize that Rachel Horn has set up. It's a new prize. She's a retired journalist and an MSer, and she's building a sort of framework for celebrating women scientists for contributions to women's health-related research in multiple sclerosis. So anything we can do to increase diversity in the scientific world, I think is going to have fantastic results in the sort of in terms of the development for services for patients as well. And this is alluding to that sort of top down and bottom up marriage of I suppose diversity and inclusion in the system as a whole that Andrea was talking about before. So I'm running out of time a little bit, but I could go on and talk about LGBTQ plus sort of audiences. I could go on to talk about education, employment, and finance in terms of socioeconomic determinants. And we know that around 70 to 80% of people drop out of employment within 5 years of diagnosis. So that's a huge area of need for multiple sclerosis. But for now, I think I'll leave it there. I've talked about ethnicity and the social challenges of being a minority within a minority. Rurality and care disparities linked to that. I've talked about the challenge of engaging male MSs in emotional and psychological support, medical gaslighting for female MSs, and the need for sort of representation from the bottom up to the top down. So yeah, thanks for having me here today, and I look forward to answering any questions shortly.
Brilliant, thank you, Rob. That was really brilliant, and I think a very contrasting perspective from Andrea's, but with the same messages at the core of it. Really tackling similar issues from very, from two different perspectives. And so we've got about 20 minutes for some questions, and we've had a couple in, so I'm going to kick off. And I'm actually going to take sort of chair's prerogative and use the one that's almost identical to one that I wrote down myself during the talks. And I think this is something that we all struggle with, which is tackling or improving health-related disparities can just feel overwhelming. And I think certainly reflecting on, my own clinical practice, you have somebody, because often these things don't come in ones, they come in sort of multiples. So, somebody may have poor healthcare related literacy and live in poverty and have, poor educational status, maybe marginalized in other ways as well. And it's like, and then you have a whole clinic, and that's one patient out of the sort of, hundreds of people that you're seeing. And of course they're individual, but you just think, where do I even begin? Like, how do I start to actually make any difference? And of course, as a clinician, you can make a difference to that person in front of you, but sort of it is really challenging knowing where to start. So I'm going to ask you both the same question, actually. So firstly to Andrea, just to give Rob's voice a bit of a rest, but he'll go first next time maybe. But Andrea, how do you start? Where do you start?
It's really a difficult but very important question. I think we need to do some introspection. We need to actually start with where we're at. And as I was saying earlier on, our evidence base is very sparse in the UK. But even before you get to that level, like what's going on in our local catchment area? So where do you work? Are we missing anyone from our clinics, for example? And you can get that information from just audits or that sort of, or service improvement projects. But I think it's a challenge, but start with what you have access to. I'll give you an example. So I work within East London, and I remember during the pandemic when we started to do remote monitoring, I was a little bit concerned that the responses that we were getting back, was from a particular demographic profile. And then I started to ask my question, I think we're missing people. And so we did an audit looking at who responded and who didn't respond. And it's a simple thing to do. But one of the things that came out of it is that our electronic system is not up to date. So when we started to tease down in terms of getting ethnicity data, a lot of people refuse to enter this information, or they say they don't want to have this information on their clinical records, which is interesting to see, because we make a lot of assumptions. So I think we can start there. What do we have access to? Our clinical records. We also have access to our patients. So what's their experience? Sometimes they'll say things in passing from your clinic. So what are they saying? Is there a pattern? Is there a theme? And what's their experience of their interaction with healthcare professionals? So I think introspection, looking at where we're at and maybe starting there, and maybe doing some work around experiences of people within our local catchment area. I think we have to start locally and then branch out.
Brilliant, thank you. And Rob, I mean, Shift MS is the kind of what's it? It's a beacon of like starting at the beginning, I guess. The whole, from the beginning of Shift. For those of us who've been there since the beginning, it started at the beginning. It started with one person at the beginning. So where would you start?
Well, we often do sort of go back to the beginning in terms of validating what we're doing as a service, questioning whether what we're doing is relevant, and I suppose, to echo Andrea's sentiment, is to go back to people living with a condition, to understanding people's experiences, to sort of validate the service that we're designing and delivering. Something that drives our research, sort of design research principle, is the sort of the idea of extremes and mainstreams. So we have a mainstream audience, but in order to cater to everyone, we need to sort of engage with those extreme audience members, and that could be any sort of level of extremity in terms of their experience. So I'd really encourage people to, in order to make sure that everyone's being met with a service design and delivery, to ensure that you're talking to people at every end of all ends of the spectrum, or both ends of the spectrum, because then the services that are delivered will be relevant for everyone. And an example of that is, something as fundamental as accessibility. If you're designing a service for someone with acute accessibility needs, that service is going to be relevant to anyone else. Video calls were a brilliant way of tackling problems with deaf communities a number of years ago. So there were services set up to help connect volunteers with deaf individuals in order to sort of essentially translate what was going on, to help people sort of navigate everyday challenges. Video calls are relevant to anyone else, but it's just a use of that technology which sort of connects an acute need. So yeah, I think there's an understanding of sort of people who are at the extreme ends of sort of user cases, and engaging with those people, and then the services that you design and deliver are relevant to everyone. Is sort of how I'd answer that.
Brilliant, thank you. And sort of leading on from that, there's a question about diversity of workforce and thinking about workforce that can sort of meet the needs of all of our patients. And one of the things that always worries me is the people that do often get shouldered with the bulk of the work to help marginalised groups are the people who are marginalised themselves. And we see this across academia, we see it across health services. Do you think, this is a question first to Rob, and then I'm going to ask Andrea, I'm going to flip your order around. Do you think this is, do you think there are ways to mitigate this in terms of getting people living with MS involved in your services? If you're trying to cater for your extremes, if you always pick the same people on the extremes, then they're shouldering the burden of everybody else, if you like, or designing a service that meets their needs. And how do we do that more equitably?
Yeah, that is a problem. I think there's from our perspective, we see sort of volunteer fatigue, if you like, or engaging with the same people again and again, and you end up catering to a very specific set of needs if you do that as well. So it's a bit of a catch-22 situation. Is we're trying to design and deliver services for people who are hard to engage with, but finding those people in the first place is incredibly difficult. And so yeah, naturally, if you do find those people, there's a tendency to go back to them frequently. I don't know what the answer is to this issue. I think it's from our perspective, it's engaging with people who are newly diagnosed, who are new to the system, who are keen to engage, whose needs are actually reflective of people who are going through that point in time. So George set up Shift.MS 15 years ago for people who are like him. He's no longer a 20-year-old MSer. So something we have to do is sort of go back to the people like George, was effectively. So we actually have to tell them to step away from design discussions sometimes, because we're not developing a service for him. The needs have evolved. So yeah, it's about sort of reconnecting, finding new people, finding ways to do that. And yeah, a way that we do it is to find those really newly diagnosed but engaged participants in our community.
All right, brilliant. And Andrea, from a healthcare perspective, healthcare and
Yeah.
research perspective, it's a big problem.
Yeah, it's a huge problem. But I touched a little bit. I know it wasn't the core thing with the presentation, but I touched a little bit on it around the workforce, because I really do believe that if you have a diverse workforce, it really helps, if especially when you're working with diverse community and community groups, because they bring their knowledge into the whole mix when we're designing services. What I was going to say as well is that access and opportunities. People need access and opportunities, and how we deal with it, it's not perfect. I agree with you. If you catch someone early on and you really empower them and they're engaged, it's wonderful. I think the challenge is people at the other end, you know. But what we do, we do a remote monitoring service at our hospital. And sometimes when I'm in discussion, like the first discussion I'm having with a patient, I'll ask them, irrespective of who they are, irrespective of their disability levels, when we ask the question, would you be happy to be involved in patient advocacy or patient engagement groups, for example, and you throw the net quite wide, because I agree with you, sometimes we tend to go back to the same people, and you do get that fatigue, but you only get one perspective as well, and it's those people who are engaged. And so I think we have to throw the net wide, and every now and then, you know, when you come across people in your clinics, you ask, would you like to be involved in any of these initiatives? And you tell them you can be actively involved, or it could be that you just read some information for us. There are different levels. So create the access, create the opportunities for people, irrespective of geographical location, irrespective of disability levels, to engage. And within our research, again, what we're doing is trying to kind of raise the awareness, because we know predominantly previously in clinical research, the research was more geared towards people who are very ambulant or mobile, or just starting to have changes there. Whereas more of our research, again, with the knowledge that we've gained over the years, is shifting towards, okay, let's see what's happening with progressive people. So with Chariot, MS, OHAD as well, clinical trials, they're very difficult to set up. They're not easy, because you have to set up research in such a way to accommodate these different disability levels. And so it's another challenge, but it can be done.
Yeah, and just to extend that last point, actually, I think, you know, inclusive research is very much a way to answer these, you know, but also to kind of get people involved in these things, and thinking more widely. And you know, certainly that we have had challenges around, you know, setting up studies that have been around, you know, very disabled participants. Actually, you need to think a lot about how you budget for transport. How do you get the patient to the study? Do you bring the study to the patient? How do you manage all of those needs? And some of the studies that I do, looking again at breastfeeding and pregnancy, really challenging to set up. But within those challenges are benefits that actually it forces you out of your comfort zone and makes you think. And I wonder if this is one way of and sort of trying to increase the diversity of researchers as well, not just by saying, well, you know, this person is diverse because of their characteristics, but actually think about like bringing in people to answer really logistical, challenging questions, and people from outside neurology, outside MS. You know, some of the most enjoyable things are working with clinicians, researchers, you know, members of the multidisciplinary team with very different backgrounds, you know, becoming very outward looking. We've got some questions coming in around MS nurses and how MS nurses can help to support. And I think that, again, I'd like to actually sort of go back to Andrea on this, and just to talk a bit about not just the role of the MS nurse, but actually the wider MDT in this support, because I think we're increasingly recognising, certainly within our own service and wider services, that there are a whole range of people within the MDT that can help to support.
That's it. Thank you very much for that question. I believe it's a very important question, actually. Personally, I believe within the MS sphere, we don't utilize a multidisciplinary team enough. And if you look at the symptoms that a person with MS can have at any point during their diagnosis, one person, to be honest, can't tackle it all. And I think as a community, we have to sort of mobilize the multidisciplinary team in a true way. And sometimes I really feel for MS nurses, to be honest, because they're carrying a lot of load. But it's the way how services are designed. And that's what I'm saying, that we need the evidence base. We need to actually push back to the powers that be and say, actually, we need a multidisciplinary approach to how we manage MS care, because it's just one more thing added to the nurse's responsibility. But the MDT team, in true MDT style, is beyond neurologists, doctors, and nurses. There's a whole array of allied health professionals that I believe is underutilized in terms of their skill area. So I think it's something that we need to address. And I know there are issues with the workforce. I know there are issues around funding, but I also believe that we should not roll over. I think we should push back and actually say what we need and advocate for our patients at a level where they're making these decisions, to be honest. The other thing I was going to say is around, you're in your clinics. I understand you have to get through your clinic list and everything, but maybe, who is the right person to actually, as I say, what we need to do is initiate a conversation. It doesn't necessarily mean that you have to deal with the whole issues. So for example, if you raise the conversation with a patient and you realize that they need some support in a particular area, then your responsibility is really to signpost that person to the next or best healthcare professional that can deal with it. And I think that's how we need to start working, and to work with the resources that we have available to us.
All right, brilliant. And Rob, any sort of reflections on the roles of different people and how to sort of, I mean, from patient perspective, not really support MS nurses, but how people integrate with healthcare services in very, we are extremely stretched in the UK.
Yeah, but, speaking from a patient perspective, any interaction with a healthcare professional is precious. So it's about how in that environment you're getting the most out of that interaction. Anything that can be done before an appointment to ensure you're sort of engaging with the right person would be incredibly valuable. Any signposting that can happen sort of before that interaction, if we are sort of engaging with a wider care team, I think would be brilliant. But yeah, there's a real demand, I think, on the part of patients for, first of all, access to care, and secondly, for sort of efficient and meaningful interactions when that does happen, because they know how sort of valuable they are.
Okay, we've just got a couple of minutes left. I was going to ask a question about sort of cause versus effect, but I think that's probably too long for our last couple of minutes. And I'm actually going to return back to the first question that I asked, and I'm going to get each of our speakers just to give their one take-home message for our audience about, in today's climate, with today's stresses, strains within the NHS, within the environment, and with the stresses and strains that all people with MS and everyone is finding and living within, what would be your one top tip for something that healthcare practitioners can do to help to mitigate healthcare disparities tomorrow in clinic? It's got to be something immediate that somebody can do. So I'm going to start with Rob.
I would say it's as simple as listening to people and understanding people's human experience and sort of perspective. I think people are more than the disease. I think disparities and I suppose diversity aside, everyone is different. Everyone's experience of MS is different. If you're asking everyone questions that unearth or surface their individual sort of needs from a human perspective, then you're already sort of thinking mainstream and extreme. You're building something into your service that can bring everyone's sort of needs to the surface. So yeah, I would just encourage people to listen to people and think about them as people with human needs. You know, in order to sort of surface those more acute needs that we've been talking about today.
Brilliant. And Andrea?
I was going to say that, and it's because, you know, I really believe in listening to the patient and coming from their perspective. But I'll just add to that, since you've already mentioned that, Rob, I'll add to, you know, one thing that you can do tomorrow in your clinic is just raise that question, because as I said, if we probably don't know because we are not asking the question. And if you don't ask the question, for example, one of those screening questions that I put up, then you probably won't know that your patient is struggling as well. So ask the question, don't be afraid to ask the question, but also look at your local catchment area. What might you be missing? You know, so some introspection is necessary as well.
Thank you. So you've both stolen the answers that I was going to give, which was to ask, because people don't often volunteer these things, and to listen. So I think on that note, on which we're unusually unanimous, it's time to draw to a close. So I'd just like to finally thank again Dr. Andrea Stennett and Rob Sloan for their excellent presentations and discussion, and thank everyone in the audience for joining and for the questions that came in, and we hope this was helpful. And thank you to Neurology Academy for putting this on. I think it's an important discussion that needs the airtime, and we've been guilty of not giving it enough airtime previously, so hopefully that can change. So thank you everyone for taking part and hosting, and we'll see you soon.